Welcome back, Baltimore. It's I Got Time with Phylicia Porter, and today we are talking about something near and dear to my heart, but it is something that me personally, my family has experienced. I've seen it firsthand as a health practitioner. I've worked in it. We are going to talk about the opioid crisis, Baltimore. And I know we have been talking about it. If you've been following me on social media for a little while, you know that we've been talking about this crisis for some time, for a couple years now. And I've never really done and had the conversation with you all just to kind of explain, one, what we're doing in Baltimore, but I really want to break it down why this crisis is so important for Baltimore, not just the city as an entirety, but neighborhood by neighborhood, block by block. I really want to go through that example with you all, and I want to go through it in the fashion that we've been talking about. So on previous episodes, we've talked about how policy impacts us at the local, state, and federal level. We're going to go through that same example today with the opioid crisis, but also we're going to take it a step further. We're going to humanize it. I feel like sometimes we are just throwing data at y'all sometimes, and I really want to break it down to humanize the data so that you can see it's not just 1,000 lives that have been lost. It's not just 73 overdoses. It's the lives that have been lost, Baltimore, the families that have been decimated, the communities that have been disinvested in for so long. That's what we're going to talk about today. Again, if you have a question, if you have a concern, share your story in the comments. I want to hear from you, Baltimore. As I keep coming back to this, this tagline, I've got time. And shout out to the people that's stopping me on the street and making sure that I have time to talk. Shout out to y'all. Y'all the real MVPs. I really do have time to explain my thought process, explain how things work, government works, and how government is supposed to work, Baltimore. So let me know in the comments, like and share this message. I want to hear from so many people across the city on how these videos can help you all really understand what's happening in Baltimore. I'm gonna break it down. So you know that I've been talking about this crisis for a little over a year now, and the committee that I chair, the Public Health and Environment Committee. During these legislative oversight hearings, my colleagues and I have been really asking questions of the Health Department, of Behavioral Health Systems Baltimore, of other health entities about what they're doing for this crisis. When we started talking about the overdose crisis, Baltimore came front and center from that New York Times article. That New York Times article put Baltimore front and center, and the data point that they used was that Baltimore had over 1,000 overdose deaths in 1 year. While I'm grateful of the notoriety, that's not something that I want to celebrate about our city. It's a reality of our city that many people have seen in communities for far too long. Right now in 2024, we're seeing record progress where Baltimore has experienced 680 overdose deaths in 2024. By no means is that success. I don't want to tout success, but I do want to show that the plan that we are on is working. Last year, we had some of the highest rates of overdose in Penn North in 48 hours. And if you were there in Penn North, you know that has been happening for decades now. It has just gotten worse. So the 73 deaths that we saw in that mass overdose, that's human lives. That's human lives, that's families that have been impacted, that's people that you may or may not know, children stepping over tragedies to go to and from school, our elders going every single day to get their medication or just to be out in community experiencing that. We need to start treating this crisis like it's more generational as opposed to something that is transactional, that if we develop a plan, it's going to change something. This crisis is going to impact not only just individuals, families, and communities. It is going to shake up systems. It's going to shake up systems so that we can truly see recovery in our communities. This is not abstract, Baltimore. This is ambulances lined up. This is people experiencing overdose coming out of their home. Syringe litter that you're seeing on the ground. Those are all aspects of this opioid crisis. What I want folks to understand, this crisis does not discriminate against race, does not discriminate against socioeconomic status, it does not discriminate against community, and it does not discriminate against gender. It is all across the board that we are seeing the decimation of this crisis. And I want to be clear with you, Baltimore, the only difference The only difference that we are seeing of the inequities of how this crisis has impacted our affluent parts of Baltimore and our underserved and undervalued parts of Baltimore is access. Access to resources, access to proper medications, access to quality health clinics, access to education about how we can truly save someone's life. When we're talking about how this crisis really approaches or exhibits in Baltimore, we're not just talking about how this crisis exists within Sandtown, Winchester, or Canton, or Fells Point. We are talking about how this crisis exists to various types of people untouched. People coming into the city, people going out of the city. They are touched by this crisis. And again, it's not impacting every neighborhood the same. The only difference between the neighborhoods is access. I want to go back a little bit because we always talk about this point of data. We always talk about how the data exists within this opioid crisis. And when you map out this crisis, you see a pattern. You see it's concentrated historically in poverty-stricken and predominantly Black communities. And this means that it's not just about drugs. It's about the economy of drugs, whether it be your dealers, whether it be your unqualified, unlicensed health clinics. It can be where people are seeing the most trauma that they've seen in generations, not just from the person, but from their children, from their grandparents, their parents. They're seeing a generational trend of trauma. It's about where we have invested in the city and where we have not invested in the city. We are seeing emerging drugs like fentanyl, xylazine that are coming into the drug market within our Black and brown communities and underinvested communities. And we are seeing the drug pattern change. We're seeing the drug pattern change where it's becoming more efficient and more evolved in a way that our approaches to how we tackle them are not even enough anymore. So for example, when you're talking about how we just had mass overdose in the Pennsylvania and North corridor, Narcan or naloxone, which are the opioid reversal drugs that are used. And the reason why I say the difference between the two, because even though they are the same drug, the way that they are administered is different, whereby you have two different medication types. We are seeing now with the influx of fentanyl within the drug economy and drug game within Baltimore, you're having to use 3 and 4 naloxones or Narcan just to reverse the opioid medication that's within that person's system, meaning that it's taking 3 or 4 times to fully revive that person from an overdose. That's not only very telling with how potent the drugs are within our city, but also it's telling from a community perspective where people, they carry one to 2 Narcans on them, but if it's taking 3 to 4, that person can potentially lose their life because we don't have the medication or the proper amount of medication to properly overdose the overdose withdrawal. In Baltimore, let me just reset a little bit. I know that was a lot. And, sometimes in my public health scientist brain, I can just be talking. But I really want you all to understand what we're discussing, but also how it's relevant for your communities as well. When people talk about harm reduction, they're like, well, Phylicia, people shouldn't have tried drugs in the first place. Granted, that may be true. But you don't know the reasons that people start. And I guarantee you, if you've experienced something in your life that was so earth-shattering, something that put you in a spiral for months, sometimes years, you just want reprieve. You just want release. You just want to feel good again. So it's not just, abstinence. It's not just saying no. That's why the DARE campaign was not successful. Prohibition of alcohol was not successful. The abstinence of sex was not successful because when public health interventions come into play, just taking it off cold turkey is never going to work. The philosophy of harm reduction is making it safe so that people can still have a life after that people are still here, that people are still alive. Harm reduction is making sure that people at the end of their addiction and they are focused on recovery, that they're still here and that they are still able to have access to recovery. It is making sure that we have access to proper medication, naloxone versus Narcan. Those are access to medications that we need in community. What we also need to see in community is outreach workers on the ground, peer recovery specialists. Shout out to T. Scott. What she is doing in the Maryland Peer Advisory Council, the advocacy work, the boots on the ground work. Vin McCormick, I see what you're doing up there. Aaron Mabin, I see what you're doing. Having actual people on the ground. That is what harm reduction is. It's real-time responses in places like Penn North. It's real-time responses in the space of, one, making sure that people have access to emergency care, but also that warm handoff so that if they are ready to go into recovery, they can go into recovery. And in Baltimore, I say when they are ready to go into recovery, because here's the thing that folks really don't understand. And you can't force someone to go into recovery. You can't. And I have literally sat by someone after an overdose, after I administered Narcan. They said, Phylicia, I just don't want to feel anymore. They said, I just don't want to feel anymore. And I said, well, let's get you into recovery. And they said, Phylicia, I don't want to feel anymore because I don't want to live anymore. And that was probably one of the hardest statements that I've ever had to hear. Because when you're trying to help someone, you just want to make sure that they're well and make sure that they're better, but you realize that they're experiencing things that you as a public health practitioner can never touch. And you still put in policies to save their life. That is what harm reduction is. That's what harm reduction is. And it comes from a place of making sure that they save themselves from themselves in some cases, but also you're making sure that in 3 to 5 to 7 years from now, when they look back over their recovery process, they will see the change that they want to see. And hopefully at that time, they are ready to get into recovery. But here's the part that people miss, Baltimore. Harm reduction costs money, and that's where the budget comes in. That's where your budget comes in. So remember, we've been going through these examples at the local, state, and federal level. So the local level, where the budget hits the block, the mayor just released his FY27 preliminary budget. At the city level, this is where residents can feel it immediately. The local budget determines how many outreach workers we're seeing. The overdose strategy from the city health department and the mayor's office of overdose response. Where those peer recovery specialists are showing up, whether it be at the Enoch Pratt Library or Lexington Market. Shout out Carl Ray. It's whether we have proper funding of naloxone within communities. Shout out T. Scott for doing the work with the Maryland Transit Association. It's where we are seeing the inspectors, the number of inspectors from the Department of Housing and Community Development that are inspecting vacant homes. That's where the local budget fits into play. Let me make it plain for you, Baltimore. If the city cuts the funding, even with all the opioid restitution funds and dollars that we're seeing coming back from the city of Baltimore suing the pharmaceutical companies, there is an opportunity for us to reach more lives, to impact more families. So imagine if those funds are cut, lives will be lost. People won't have access. Remember, I keep coming back to this idea of access. Baltimore, the local budget is so important for us when we look at how this crisis is truly going to impact Baltimore, but how it's going to impact Baltimore 30 and 50 years down the line. So Baltimore, I'm going to go to the state budget now. I often tell people, when we really want to look at how to target services, we have to look at the budget behind those services, which largely resides at the state level. So remember I said that the city budget is where the budget hits the block for all of the opioid crisis. The state budget is the system behind those services. So we're talking about Medicaid reimbursement for addiction treatment. We're talking about licensing and oversight of healthcare clinics. We are doing some things here at the city level, which we're trying to push the mark. but largely the oversight of healthcare clinics, the number and quality of healthcare clinics resides at the state level. Major funding to local health departments resides at the state level. Behavioral health infrastructure across Maryland resides at the state level. And so here's why it matters, Baltimore. If Medicaid doesn't pay enough, providers don't expand and they cannot provide the quality of services that they need. If oversight is weak, communities feel it most. Those unlicensed recovery homes that are existing in your neighborhood, those unlicensed health clinics that are providing lack of quality of services, that is where you feel it. You know, when people ask, why aren't there enough treatment options? I go through this process with them, like say, hey, this is how we work with our local behavioral health authority. This is how we work with our local and state representatives to ensure that we have alignment at both levels. And also Baltimore, when we see just the crazy amount of clinics that are not providing great care in Baltimore, they're looking at us as city council, but they need to be looking at their state representatives to see how we can change the laws, the regulations at the state level to put more restrictions on quality, but also enforcing the restrictions and also enforcing the regulations that we currently have on the books. That's that tug and pull that we are fighting currently within my committee. And I'll tell you, it's a very collaborative process. I work very well with our local behavioral health authority, with our representatives at the state level in the Maryland Department of Health. I work very well with legislators that are trying to move the needle as it relates to policy and how policy really shows up in communities. Now we're talking about the federal budget, the source behind the resources. And this is where the largest investment originates from. Federal funding supports naloxone distributions at scale. It supports public health grants to our local health department. It supports substance abuse expansion, research and data systems. And let's be very real, Baltimore. Many of these programs are saving lives and many of them are not. So ask yourself a question, Baltimore. Say self. Self says what? If federal funding is reduced or shrink, who do you think is going to feel it first? It's going to be you, Baltimore. It's going to be you. You are going to feel it. Outreach shrinks, programs close, and progress slows. That is who feels it most, Baltimore. And that is what we are talking about with this opioid crisis. So you know why I'm telling you this, Baltimore? Because this moment requires real leadership. This moment requires active leadership. It requires creative leadership because we can hold two truths. We can hold compassion for those that are experiencing addiction and an active recovery. We can hold that, but we can also hold truth to ensure that our neighborhoods are safer, are feeling stable, and Baltimore feeling respected and dignified. And if we fail to balance both, we lose trust. We lose lack of empowerment in communities. We get the NIMBYism, the not in my backyard approach. And without trust, the policy does not work. So again, please stay tuned. Let me know in the comment section. Let me know your questions. We all have to be working on one sheet of music in order to really make this thing work. Because the policy is no good if we don't have the political will. The political will is no good if we don't have the budgetary documents that align. The budgetary documents are no good if we do not have elected officials that are constantly going to demand the outcomes for their community through our formal and informal functions of our office. We gotta get this right, Baltimore. So I'll see you next time with I Got Time with Phylicia Porter. Talk soon, Baltimore.